Next up with our PQI Clinical Overview is Jody Agena, clinical pharmacist at Virginia Cancer Specialists. Jody will speak about the PQI that he wrote on Ibrutinib Management. Jody.
Thanks, Stephen. I'm going to go through a quick overview of the PQI that we all collaborated on and wrote up on Ibrutinib Management. First off, Ibrutinib is a small molecule that acts as a potent, irreversible inhibitor of Bruton's tyrosine kinase, a key component of the B-cell receptor and cytokine receptor pathway. BTK inhibition is vital for decreased malignant B-cell proliferation and survival. This molecule disrupts the proliferation of B-cell cancers, such as mantle cell lymphoma, chronic lymphocytic leukemia, marginal zone lymphoma, and Waldenstrom's macroglobulinemia. Managing both medication dosing and adverse effects are prime examples of key areas for additional intervention opportunities for improved patient health outcomes within the medically integrated team. Dosing of Ibrutinib varies by disease and indication, and should be carefully assessed. Although the dose may stabilize over time, drug interactions frequently occur with common anti-infective agents. Of note, lymphocytosis is a noted adverse effect of the drug, which results in increased counts of lymphocytes in the blood. It's a common and expected occurrence, which does not reflect the progression of disease, and action should not be taken upon this. Monitoring patient laboratory values must be considered and evaluated based on patient's needs. Upon receiving a new prescription of Ibrutinib, the PQI process begins as first confirming the appropriate dose and making sure that it corresponds to the appropriate indication, monitoring CBCs at baseline, monthly, and as clinically necessary, monitoring chemistries, uric acid levels at baseline, monthly, and as clinically necessary, as well as looking at taking an EKG at baseline, especially for patients with positive cardiac history or risk factors associated, and as periodically necessary. We must also evaluate patients that are on anticoagulation, including aspirin, for the increased bleeding risk. The use of anticoagulation with Ibrutinib should also be assessed with each patient based on risk versus benefit. It's also recommended to withhold treatment 3 days pre and post for minor surgical procedures and pre and post for 7 days for major surgeries. Consider PJP prophylaxis in patients with increased risk of opportunistic infections. Note that lymphocytosis, as mentioned before, is a common occurrence and usually resolves by week 8 of therapy. And again, it does not reflect disease progression. Lastly, monitor for drug interactions, adherence, and adverse events. The dosing guidelines are as follows, with the references listed on the right-hand side. But for CLL, the dose is 420 daily. Mantle cell 560, marginal zone 560 milligrams. Waldenstrom's is 420, and it also has a chronic GVHD indication, which is 420 milligrams as well. Adverse effects that are associated with Ibrutinib are, we listed the most prevalent adverse reactions from top to bottom. So diarrhea, fatigue, musculoskeletal pain, peripheral edema, respiratory tract infections, nausea, vomiting, and bruising. The grade 3s and above, grade 3 and 4 adverse reactions are listed on the right-hand side with hemorrhage, infections, cytopenias, cardiac arrhythmias, secondary malignancies, and hypertension. Recommended dose modifications for toxicity. So on your first toxicity occurrence in the mantle cell and the marginal zone space, when your starting dose is 560, you're going to go down one dose level to 420. Oh, I'm sorry. On your first occurrence, you're going to restart at 560. And then on your second occurrence, you're going to go down to 420, and then 280, and then discontinue. As far as the other indications where your starting dose is 420, you're going to go down to 280, down to 140, and then you discontinue thereafter. As far as patient-centered activities where we can help with the care of the patient, providing an oncology chemotherapy education sheet is vital. Ensuring that each and every patient understands the formulation prescribed and how to take the dose. Of note, when this medication first came out, it was only available in capsules. Now they're available in tablets and capsules. So it's important for the pharmacy technician as well as the pharmacist to understand the dosage forms and the available dosage forms on which they come. For the most part, patients are going to administer once daily. It's usually one tablet, but sometimes capsules, orally once daily with a glass of water. Swallow the capsules or tablets whole. If a dose of ibrutinib is not taken at the scheduled time, it can be taken on as soon as possible on the same day, but we want to urge patients not to double up. As far as signs and symptoms of monitoring, abnormal bruising, bleeding, especially those on anticoags, GI tolerance concerns, nausea, vomiting, diarrhea, as well as assessing any new medications for risk of QT prolongation, drug-drug interactions, as well as with anti-infective drugs. Lastly, adherence is a big part. Evaluate if patient has missed any doses between cycles and determine if interventions are needed. Lastly, Ibrutinib management, drug interactions. CYP3A4 inducers, strong inducers, will decrease or may decrease the serum concentration of ibrutinib, i.e. carbamazepine, rifampin, phenytoin, and St. John's wort. The recommendation is to avoid. As far as CYP3A4 inhibitors, parentheses strong, this may increase the concentration of ibrutinib. Avoid concomitant use of ibrutinib and strong CYP3A4 inhibitors together. And this is ketoconazole, itraconazole, voriconazole, pulsaconazole, clarithromycin, and telithromycin. The recommendation is to avoid these as well. Live vaccines are something that may diminish, immunosuppressants may enhance the toxic effect of vaccines and may diminish the therapeutic effect of the vaccine. So you should avoid live vaccines. Live attenuated vaccines should not be given for at least 3 months after immunosuppressants. Warfarin and other anticoagulants increases the bleeding risk. This is secondary analysis to the Resonate trial, where phase 1 study participants on anticoagulation and ibrutinib, and what they found was that ibrutinib acts as a anticoagulant and increases the bleeding risk in 10 to 20% of these patients. These events were typically observed in conjunction with other factors such as coexisting medical conditions and/or concurrent medications. And lastly, the references, and if there's any questions or concerns with these, you can email me or contact me there.
Thank you so much. Thanks so much, Jody, for that great presentation. And if anyone does have questions, please feel free to enter those in the chat or Q&A box, and we'll be sure to get to those. In the interest of time, we are going to move on to our next presentation. Also, Jody's PQI on Ibrutinib Management will be available on the NCODA website this afternoon. Thanks again, Jody.